Welcome to Improving Work Outcomes in Patients with Musculoskeletal Pain, Effectiveness and Costs of a Vocational Advice Service. We're glad you're here. My name is Yusra Benjeloun, Administrative Coordinator and Project Manager with the Work Wellness and Disability Prevention Institute, and I'll be co-moderating the webinar today. This webinar is made possible through the support of the Community Gaming Grant Program through the BC government, as well as donations and memberships to WWDPI. We thank our program partners, Pain BC, Sport Chronic Pain Network, Canadian Council on Rehabilitation and Work, Education Advisory Committee, and speakers who contribute to this webinar series. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions you have related to the presentation. We will collect questions submitted throughout the presentation and follow the presentation with a Q&A based on the questions submitted. Following the webinar, any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website along with the slides. You will be emailed the direct links for all of these items when they're available. Today's webinar is co-moderated by Joy Raymond, Treasurer and Trustee at the Vocational Rehabilitation Association in the UK. Joy will be running our Q&A session, and I will let her introduce our presenter, Dr. Gwenllian and Wynne-Jones. Thank you both for being with us today.
Thank you very much, and it's a pleasure, Yusra. I wanted to say a big welcome to those of you in North America, and a lovely rainy afternoon here in the UK. And for those of you in Australia who are burning the midnight oil, welcome as well. My name's Joy Raymond, and I'm just delighted to introduce Dr. Gwen Wynne-Jones, and she'll be our speaker today. Gwen initially trained as a nurse. Her PhD research focused on the epidemiology of pain, specifically examining the role of trauma in the new onset of widespread pain. She joined the Primary Care Centre versus Arthritis at Keele University in 2005 as a research associate, and then as the UK's National Institute for Health Research, NIHR, Research Fellow, and NIHR Clinical Trials Fellow. Gwen's research activities focus on examining the impact of health on work and how this can best be managed. She is particularly interested in the prognosis and management of musculoskeletal pain and other conditions commonly seen in primary care, such as mild mental health disorders. Gwen, it's a pleasure to have you here, and I'm going to hand the baton over to you to begin our presentation, and welcome.
Thank you very much, Joy, and thank you, Yusra, as well, for inviting me to present this webinar. It's a real pleasure to be able to discuss this topic with you all across the globe. It's fantastic and very exciting for me, I think. So I'm going to start by setting out the context as to why we undertook the study of work and pain, or the SWAP trial of vocational advice. The context is quite UK focused by necessity, but I think you'll agree that the principles apply to many countries, and the trial in itself will certainly apply internationally. I think there's a lot we can take away from this small UK study. So just starting with the objectives that I want to achieve today. The first is to look at the impact of musculoskeletal pain on the working age population, to consider the value of working despite having musculoskeletal pain, and I'm then going to provide an overview of the findings from a randomised controlled trial where we compared a brief early intervention to support people working with pain, the best current care within our UK primary care setting. So musculoskeletal conditions are a broad range of health conditions, affecting the bones, joints, muscles and the spine as well. They often interfere with people's ability to carry out their normal daily activities. And the most common symptoms are pain, stiffness, a loss or reduced mobility, and participation as desired in life. So they really are stopping people taking part in life as they wish. The most common types of musculoskeletal pain are osteoarthritis and back pain, one of the biggest. Versus Arthritis is a key patient charity in the UK, and just last year they brought together this evidence summary, which is freely available on their website. about the scale of the impact of musculoskeletal conditions within the UK. So I just wanted to pick out some of the more interesting facts from this report to really try and highlight what we're dealing with. So an estimated 17.8 million people live with a musculoskeletal condition within the UK. That's around 29% of our population overall, affects men and women, slightly more common in women. The pain and disability caused by musculoskeletal conditions result in a substantial loss in quality of life, has a considerable impact on our healthcare system, with the National Health Service reporting that about 1 in 5 people consulting their general practitioner or primary care practitioner each year for a musculoskeletal condition. About 1.36 million admissions to consultant care in England alone, so that doesn't include Scotland, Wales and Northern Ireland here. And there are 2.27 million bed days, so days in hospital as a result of musculoskeletal conditions. They account for the 3rd largest area of spending within our NHS at about £4.7 billion per year. So it's a very costly condition, and understandably it has a cost on our economy as well, and this has been estimated to be around about £10.2 billion in direct costs to the NHS and the healthcare system more broadly. The most affected groups in our population are those of working age and those who are on the older age groups as well. But musculoskeletal conditions are also a leading cause of sickness absence, with 31 million working days estimated to be lost per year. So it counts for nearly a quarter of our total sickness absence if you exclude things like coughs and colds and general sickness. And people with musculoskeletal conditions are less likely to be in work than those without health conditions, and they're also much more likely to retire early, which also has an impact on our economy. But the challenge is rather like an iceberg. Those with diagnosed conditions such as osteoarthritis are only the tip of this iceberg in our population, and there's a much larger proportion of people who are seeking care within primary care with symptoms of musculoskeletal pain. So those who are work active with frequent and recurrent musculoskeletal pain in one or more body regions and going about their daily lives make up around about 50% of our population. But it's only the small population who actually have a diagnosed health condition. If we look at the proportions of people who take time off work as a result of their musculoskeletal pain, in the UK we now use something called a statement of fitness for work, or a fit note, which is required for periods of work absence over 7 days. And these fit notes are signed by a medical practitioner, and that could be your GP or it could be a consultant in the hospital. And this slide summarises the UK rates of certification or fit notes for musculoskeletal conditions across the different age groups. So about 30% of people who consult with an episode of pain will receive a fit note for that consultation, and the rates are highest in our working age adults and also in those with sciatica and back pain. So you can see we have a slight spike in sort of rising from the 40 age group right through to those in their 60s. And there's a slight drop off in the older age groups, and that's a historical drop off from our retirement ages that are now no longer relevant. But our research has shown that 6 months after receiving a fit note, there's actually little change in patients' anxiety, their depression, their pain scores, their reported disability. So that shows us that actually these fit notes aren't solving the problem of musculoskeletal pain, they're just providing us short breathing space for people to take time away from the workplace. We've also shown that within this group, productivity losses whilst people are at work are significantly higher for those who have received a fit note, with a mean difference in costs due to absenteeism over 6 months of around £2,000 for people with back pain. So writing a fit note and taking a period away from work is costly not only in terms of the monetary value, but also in terms of people's health as well. Our understanding of the impact of health and work has been steadily growing over the past 10 to 15 years. We now know that work is generally good for physical and mental health and well-being. We know that the longer the duration of sickness absence, the more entrenched incapacity can become, and obstacles to returning to work become much greater. And it's much harder then for people to get back into the workplace. So early intervention is therefore very important if we want to avoid these consequences. But the provision of occupational health in the workplace in the UK, where most employees work in small and medium enterprises without an occupational health service within those organisations, the process of support is currently limited. People need to go through the health service to get any type of occupational health support when you work in these smaller organisations. But that brings its own challenges. So the problem or the challenge that we faced is really summarised on this slide. For the vast majority of employees, the first line of occupational health care is their general practitioner or their primary care clinician. This is most often a GP, but might be a practice nurse or a physiotherapist more frequently. But these clinicians, and particularly GPs or general practitioners, report difficulty in managing a consultation where a sickness certificate or a fit note is an option, so where they might consider certifying someone absent from the workplace. They report that they don't have the skills to undertake fitness for work assessments, which if you do them well are quite comprehensive. The majority of GPs have little or no training in fitness for work assessments or in managing the fit note process, and they have 10 minutes per consultation with a patient, deal with their health condition, refer on to other services that they might need, and write prescriptions, as well as assessing a patient's ability to work. But patients and GPs often have inaccurate views on working with health conditions. Patients aren't provided with the skills then to manage their pain in the context of their work. And we're seeing that there's a repeating cycle of a flare-up of pain, consulting in primary care, and taking a period of work absence. So we hypothesised that intervening at the level of the primary care consultation with a vocational advice service to support patients with musculoskeletal problems to remain in work or to return to work could lead to a faster return to work and fewer absences over the longer term. So our key challenge was how to help people with musculoskeletal pain to stay at or return to work, and we needed an early and brief intervention in primary care to support this. So that led us to the development of the Study of Work and Pain, or the SWAP, Cluster Randomised Controlled Trial of our Vocational Advice Service. The aim of this trial was to test the effectiveness and cost effectiveness of adding an early vocational advice service to best current primary care for adults consulting with musculoskeletal pain. So our key outcomes were looking at days lost from work and the number of fit notes that patients had been issued by their medical staff. We recorded our data through patient questionnaires, and we also undertook medical record reviews of patients' clinical records within their GP practices. So just a little bit of background as to the type of study design that we used. We chose a cluster randomised controlled trial design, which is in the top left-hand corner here. It's a pragmatic design with 2 parallel arms. We had a health economic evaluation and nested qualitative interviews within our study. So a cluster design essentially tells us that the unit of randomisation was our general practice, our primary care practice, with data collected from individual participants. And we randomised 6 general practices who were matched on practice size, 3 to provide best current primary care for managing the impact of pain on work, and 3 to provide the same, plus the addition of a vocational advice service, which was located in the practice and staffed by trained vocational advisors who provided occupational advice about working with musculoskeletal conditions. So to be eligible to get into our study, patients needed to be adults and consulting with any musculoskeletal pain condition, and we had people included with neck pain right down to pain in their toes, so we incorporated all musculoskeletal conditions. They had to be currently in paid employment, but either absent from work or struggling to remain at work as a result of their pain condition. If they were absent from work, their absence needed to be less than 6 months. And the reason for that is within the UK, at 6 months, there are national level interventions that patients can then access to try and support them in returning to work. We excluded individuals who had serious medical conditions that required urgent attention, those with serious mental health conditions for whom participation in the study would be detrimental to their health, and this was at the discretion of their general practitioner, and also those who were pregnant or on maternity leave, because the interventions to support these individuals would be quite different. So what do we mean when we say best current care? So those individuals who were randomised to our best current care arm received, their general practitioners received some training from ourselves around what best current care for the management of musculoskeletal pain and work was. This included providing them with key messages that work is usually good for people with musculoskeletal pain, that long periods of absence can be harmful, that musculoskeletal pain can often be accommodated at work, and that planning and supporting return to work are important in good clinical management of pain conditions. All usual healthcare continued as normal. So if participants needed to be referred to other services or needed a prescription, those carried on as usual. So if we consider what was included in our vocational advice arm of this trial, our vocational advice was based on the FLAGS model of management, which focuses on the identification of obstacles to working with health conditions. And this diagram is taken from the report by Kendall in 2009, Tackling Musculoskeletal Problems, a Guide for the Clinic and Workplace, and identifying obstacles using the psychosocial FLAGS framework. So we use this framework to spot those individual difficulties that each patient has, and they will be very different for each individual patient, and to look at the obstacles that they're coming up with, try and identify a practical strategy that patients can put in place to overcome obstacles to working. So these are to take action to address these issues and re-evaluate the patient's situation very regularly until a sustained return to work is achieved. So we deliberately designed our vocational advice service to be very light touch in its approach and based around the principles of case management and stepped care. So our vocational advisors provided a goal-oriented approach to return to work or remaining in work. They coordinated and facilitated communication. They worked collaboratively with treatment providers, the employee, and where needed and with permission from the employee, their workplace as well. And patients were able to step up the support they received from our vocational advisors when they needed it. The intervention development had stakeholder involvement from our general practitioners, work disability advisors, vocational advisors, and very importantly, from the patients that we were trying to support. So if we look then at a model of our intervention, step one was addressing unhelpful beliefs about working with musculoskeletal pain. Looked at discussing obstacles to return to work using the FLAGS framework to structure that. And we tried to set the date for return to work with that individual patient. Those individuals who struggled to return to work were eligible to step up to step two. And this was the identification of potential obstacles to work and really targeting practical strategies.
Sorry, Gwen. Sorry to interrupt you. I'm so sorry.
Okay.
I believe there's if you could just speak next to the microphone.
Oh, are we losing me a little bit?
Yes,
Okay.
we do lose you a little bit. Thank you so
Start.
much.
That's okay. I will start with step two. So step two is looking at the practical strategies to support people to return to work. And this is looking at potential fear avoidance. So are people worried about going back to work and how it will affect their pain? Do they need support in how they communicate their condition and their requirements with their employers so that they can get accommodations in place within the workplace? Step three, we looked at reinforcing messages and targeting of any additional obstacles that people might have to returning to work. But also we offered involvement with the workplace. So our vocational advisors would act here as particular case managers and talk to the workplace on behalf of the patient if that was required. All of our vocational advisors completed case report forms so that they could develop a plan in conjunction with our patients to manage their pain at work. So step one was done only by telephone. So we phoned people up so they could contact us at any time, wherever they were, whether that was from a home base or whether that was from their workplace. Steps 2 and 3 were commonly done face-to-face, dependent on patient preference here as well. So we tried to minimise the amount of time we were taking out of patients' working days if they were remaining at work. So our vocational advice service was delivered by 3 physiotherapists. They were all very experienced in musculoskeletal pain, but we asked them not to deliver traditional physiotherapy treatments as part of this intervention. They participated in a training program and they received monthly mentoring sessions around delivering the intervention. The training program was 4 days with a 1-day refresher before they started seeing their patients. The vocational advice service was offered from participants' GP practices, and this was because patients were concerned about visiting offices that might have an influence on their sickness absence benefits, and the general practice was felt by patients to be a neutral territory here. So in terms of what we measured, we were looking at days off work as being our primary outcome over 4 months. The aim of the trial was to reduce the number of days that patients had away from the workplace, but we were also interested in whether patients were using self-reported time off work, whether they had GP certified time away from the workplace, whether they felt confident about returning to work, so return to work self-efficacy, whether their pain intensity was reduced, whether the bothersomeness of their pain was reduced, and whether there was a change in their pain over the period of the trial. And lastly, we asked them about their performance in the workplace and whether they felt that they were performing as well as they would without pain. So our sample was powered to detect at least a difference of 10 days between our two arms in this trial, and we recruited a total of 338 participants. In fact, we were aiming for 330 across the 2 arms of the trial. So that's a brief overview of what we did, but the more exciting part is what we found and how this intervention, which was brief and delivered mainly by telephone, impacted on our patients. So we recruited 338 participants in total. 158 were in our intervention arm and received our vocational advice service. 180 were in our control arm and received care as usual. We managed to follow up 79% of our people and 72% at 4 and 12 months respectively. So once people were in the trial, the majority of them stayed with us, which is fantastic. So who did we get in this trial? What did our patient population look like? Well, the mean age of participants was about 49 or 47 years in our intervention and control group respectively. If you think back to the graph I showed you earlier on, this is where we see the peak in terms of work absence. So we're getting the right people into this trial. We have slightly more women than men in the trial, and we found that the majority of these people were working full-time, so just over 2/3 of people were working in full-time positions as opposed to part-time. Their number of days off work over the past 12 months averaged a little over 2 weeks, but ranged quite considerably in our intervention and in our control groups. At baseline, we found that the duration of symptoms, so how much pain they'd had, the measures of pain intensity, and how bothersome they found that pain were very similar for both arms. So the level of pain was quite similar for both of our groups. Analysis of our case report forms demonstrated that the vast majority of people who used the vocational advice service received the intervention by telephone only, about 90% of people in our trial. The average number of telephone contacts was 2, and most of these phone calls lasted little over 13 minutes. So very, very light touch here. The main obstacles that we were identifying here to stay at work or return to work were the symptom severity and participants' perceptions regarding the relationship between work and health and a perceived lack of modified work duties. I say perceived here because we're going by patient report rather than us talking to the employers at this point. But those individuals who stepped up to face-to-face contacts, about 9% of them, and that lasted around about an hour, and we had just 1 workplace visit within this trial. So if we look at the results that we found at 4 months, so our primary outcome measure, when we looked at days off work, there was a significant difference in the number of days of absence between our intervention and our control arms. Those in our intervention reported they'd had a mean of 9 days away from the workplace, compared to 14 in our control group. So that difference is 5 days or a full working week. And the right-hand column there tells us that that was statistically significant, but I would argue a full working week is more of a social significance than statistics. This difference was mainly in our primary care certified absence. So we were finding that actually our intervention group were reporting that they had fewer days certified by their GP, and they did have a little bit more self-certified absence. If we look at some of our secondary outcome measures, so we want to look at whether we changed any of the measures or performance within the workplace, we can see that individuals in our intervention arm had reduced presenteeism scales. So when they were at work, they felt better at work. We increased self-efficacy to return to work, or how confident people felt in managing to get back to work after a period of absence. There was no effect on satisfaction with work, but we did increase individuals' performance when they were in the workplace. So when people were at work, they felt they were doing their job better than they had done when they were experiencing their pain beforehand. At 12 months, the confidence to return to work and the performance at work were maintained. So people were managing to get back to work themselves, and when they were there, they were performing better, as they reported. Going to look at the cost effectiveness analysis and our cost benefit analyses. Given the 1 working week difference in absence, it's perhaps not surprising that our vocational advice service resulted in greater mean benefits in terms of days off work. There was slightly higher NHS and healthcare costs, a mean difference of about £48. But that results in an incremental cost effectiveness ratio of about £7.20 per sick day avoided. But this resulted in a net societal benefit, so a positive outcome, of £763 in favour of the vocational advice service. And if you consider this on a purely business perspective and look at return on investment, the service provided a return on investment of £49 for every £1 invested in this service. So on a societal level, this is an incredibly cost-effective intervention. But I mentioned earlier that we had undertaken some qualitative analysis as part of this trial. So I'm going to present some of the qualitative findings that we have here. We interviewed our general practitioners, our primary care providers, our vocational advisors, and our patients to gain their views on whether or not the vocational advice intervention was useful to them, and how they felt about this type of intervention being undertaken within primary care. So overall, our GPs felt that vocational advisors could provide an alternative way of managing patients who had complex work-related difficulties. But they felt there was a bit of a lack of interaction and engagement between themselves and the vocational advisors. This was as a result of this being a very new service within the UK. This is the first time an intervention of this nature has been trialled. And we find that actually interaction and engagement develops over time. But our GPs also felt that perhaps the timing of our intervention was too early for some of the patients. So if you recall, some of our patients hadn't had a period of work absence. They were struggling at work rather than being absent. And the general practitioners felt that perhaps it was too soon to start offering them vocational advice. But I've just put a couple of quotes here from our general practitioners who were quite positive about the intervention, and one that talks about how confident you are when you're not referring many people. So GP number 8 says, I think that's what really comes over as being very useful, is that they have the time to discuss things. I mean, we have 12 minutes and it's really not long enough for people to express their concerns, really. So the advantage of this service was it gave a greater platform for discussion of how an individual patient's pain condition was impacting on their work and how they could talk about that to work out a pathway through managing their health and work. GP number 5 talked about embedding the service and how it's difficult to get that embedded service when you're only running this for a short time. If you're only referring one patient every 3 or 4 weeks, you're not that confident about what the service can do. You're not getting that kind of feedback. And when you start referring a few more, you see that there is positive benefits to it. So taking time to embed a new service within a healthcare service is very important. And once clinicians start seeing that positive feedback, you find that they use services more, and that can only be of benefit to their patients. When we talked to our vocational advisors, they also noted the difficulties in engaging with their general practitioners. There was a need for some soft conversations to foster a greater engagement and awareness of the vocational advisor role. So they would often collar the clinicians in corridors or in the tea room while they were making a cup of tea, talk about what their service was delivering and the benefits that could provide for the patients. General practitioners needed to be very confident that the vocational advisors were part of the primary care team for them to be able to make sense of their role, either as separate or connected to what the GP could offer their patients. There were some role tensions between our vocational advisors' existing professional training, which was as a physiotherapist, which they were discouraged to deploy, and their new role as a vocational advisor. And this was particularly apparent where patients were self-managing their condition in the context of their work. Vocational advisors were also concerned about the potential of them de-skilling their physiotherapy roles, and when questioned whether it would be more sensible to combine the role of vocational advisor with physiotherapist, they felt that that could be useful in some instances. So again, if we look at some of our interview quotes from our vocational advisors at 6 months into the study, the first one noted that they had to demonstrate that they were adding value to the patients, which is difficult to do when the patient is being referred so early down the line. So the difficulty is weeding out those who really need the advice and adding value really to the service itself, because essentially we're just contacting patients who have already put together a return to work plan, and we're not going to be adding value. So where patients are self-managing their condition, there needs to be an element of sensitivity. And as with the general practitioners, perhaps it was felt that this intervention was offered a little bit too early for some of the patients. And another quote looking at the difficulty between switching off a physiotherapy hat, I think you do go back to your comfort zone. I just know physio, and I know I'm happy with that, and I can see the benefit of it. This is such a new role that that's difficult to see sometimes. So there was an element of needing to embed this role within practice and within services before you can start to see the benefits and before you can really add value to patients and provide them with good care. But if we consider what our patients were telling us, they often felt, again, some of them, they were referred to the service a little bit too early, particularly where they were self-managing their pain and had already planned to go back to work. And this echoed the sentiments of both our vocational advisors and our general practitioners. But patients did appreciate the impartial advice provided by the vocational advisors. So if we look at patient 34, I can see obviously it would be of tremendous help to some people. I think I was quite lucky. So although I've got a long-term problem, it's not unmanageable. Do you know what I mean? So this patient was expressing that they could see the value of the service, particularly for patients who were struggling to manage their pain condition. And patient 338 noted that it was good to have the phone call support, which was more independent, because that was over the telephone and I felt that he was looking after my best interests rather than work's. The occupational health lady was looking after work rather than, and the patient went on to discuss the differences between that and having that real impartial advice. Patients also appreciated some of the less tangible benefits from the service, such as having someone to talk to and the provision of legitimacy or validation of their problem. With pain being an unseen problem for many patients, that legitimacy or validation is really very important for them. So patients would report, and this is patient 636, you felt that you'd got somebody else on your side and supporting you really. Because, you know, if you've got a broken arm, they can see it. It's in a cast and whatever. Whereas, you know, they do say a lot of people put on the fact that they've got back pain, depression or whatever. So there was a real strong sense,
of having this impartial advice provided by vocational advisors, legitimising their pain condition. So to conclude, we found that adding an early, brief and low intensity vocational advice service for adults with musculoskeletal pain in primary care was associated with significantly fewer days absent over a period of 4 months. Referral to the vocational advice service was associated with greater economic benefits than best current care alone. And the intervention appeared to improve return to work self-efficacy, so confidence in managing return to work, presenteeism, so people were less likely to be at work when they shouldn't be, and performance at work was increased as well. People reported that they were managing their jobs better and performing better after receiving this vocational advice. So what are the key messages that we can offer from this randomised controlled trial? Well, we've noted that we can offer early and low intensity advice and support. We can do that in primary care, so when a patient first consults a clinician reporting their back pain. But importantly, we can do it in ways that provide reassurance and support self-management. We can do it in a way that engages individuals in a return to work plan. And we can do it in a way that patients are in control of managing that return to work plan, identifying the difficulties they have and working out how they can overcome those difficulties to manage their pain in the context of their work. We've also identified that those with long-term conditions and or long-standing work difficulties were felt to particularly benefit from this intervention. And we've identified promising strategies that can reduce days lost from work and increase patients' confidence in managing their musculoskeletal pain at work. So work for us, most of us, is a part of life, and if we're integrating work into healthcare consultations, this has been shown on the broader stage over and above this trial to have more positive effects for individuals, for their individual health and for societal systems. So providing vocational advice whenever a patient contacts a healthcare professional is really very important. And providing that consistent message across health professionals is also important to reinforce the positivity around working with health conditions. But we've demonstrated that early primary care oriented initiatives that help people stay in the workforce with their health condition need to be further developed and tested. Whilst this was a very positive randomised controlled trial, it is very small and it focuses on one health condition alone, musculoskeletal pain. But I think it demonstrates that we can work towards generating this type of intervention for people regardless of their health condition. So what are we doing in the future? Well, we're using the results of this trial to undertake some further research. We have our I-SWAP study, so our implementation of the learning of the study of work and pain. And this is developing our vocational advice training into an online module that will be accessible to healthcare providers across the country. We're testing this with first contact practitioners, and these are physiotherapists who work in self-referral services within the UK. And this work is funded by the Joint Health and Work Department, which is an initiative run by the Department for Work and Pensions and the Department of Health and Social Care within the UK. Alongside this implementation study, we are developing the WAVE trial, which is the Work and Vocational Advice trial. And this takes the vocational advice service I've described within this presentation, and we're adapting it so that it's suitable for many more patients consulting in primary care with health conditions affecting their ability to work. It will be open to all health conditions and not just musculoskeletal pain. We're aiming in this trial to provide good quality advice and support for return to work to patients who are already absent, but before that absence becomes long-term. So we've taken note of what our patients, vocational advisors and GPs have told us about offering the service too early, and we're waiting until people have had 2 weeks of absence for this new trial. And this has been funded by our National Institute for Health Research Health Technology Assessment Programme, and the results of this will be ready in 2024. So lastly, I'd just like to acknowledge the huge array of people who have supported this trial, the patients and GP practices who took part, our vocational advisors, our SWAP study team, and also our funders for this trial, who were again the National Institute of Health Research. And I would just like to thank you all for listening, and I look forward to hearing your questions. Thank you very much.
It helps if I unmute myself, but to say a big thank you to you, Gwen, that was a fantastic presentation, and I've been writing little questions myself, but I will try not to I'll try not to hog the mic, as it were. There are some questions that I'd like to pass on from attendees, and if you're okay to take them now.
Yep, that's absolutely fine.
That's great. That's lovely, and we've got plenty of time, so please do write in your questions, and we'd be glad to put them to Gwen. The first is, which strategies were the most effective in reducing absenteeism? Can you elaborate a bit more on this, please?
I can, to a certain degree. I think overall the intervention as it stood was the most effective in reducing absenteeism. But doing a little bit of digging and discussion with our vocational advisors, we found that one of the most useful things was literally just raising the question of work. A lot of patients reported that it wasn't something that was discussed in their consultations with their clinicians. So having the space and the opportunity to discuss how their health impacted on their work really allowed them to see where they could make changes and where they could ask for support from their employers. So some of the obstacles we discussed was around communication with employers, so giving people the skills to open that conversation and say, I've got a health problem, it's impacting on my work. This is what I think would help me remain at work. Can you support that? So providing people with those skills. But also a bit of goal setting around trying to get back to work and putting in a return to work date. We find that people are very good at predicting when they will get back to work. So if you ask them the question, you can really make use of that and encourage and support them through that timeline to get themselves back to work when they're ready to do that. I don't know if that's I hope so.
That sounds lovely. I just had a question from myself in it just to ask, was that advice and the further exploration part of the step 2? Or was it actually in the step 1 part of the process that 90% of your candidates received?
So it would have cut across both of those. In step 1, we would talk to people about the positivity of returning to work and keeping active. We would also use our flags framework, so we would ask people about what issues are around there in the workplace. Is there the availability of modified duties for you to do? Are you able to get up and walk around for 5 minutes every hour at work, for example, if the patient felt that would help them? A lot of it was around the clinical or yellow flags. So patients were reporting that their pain wasn't well managed. And again, sending them back to their general practitioner to manage that pain better was very helpful for those patients. And this would straddle across step 1 and step 2. We found that in step 2, people probably had more obstacles to working and required a bit more time to work through those and work out solutions. But certainly in step 1, we would provide some of that advice as well.
That's great. That's great. Question 2, and this is something I was interested in very much when I heard about the ISWAP study. The question is, what initial feedback do you have from this study?
So the ISWAP study is still underway. We're still collecting data to evaluate that at the moment, and the results of that will be completed in February, is when our final report is due. Initially, I would say that during the development of our online training module, we included our first contact practitioners or our physiotherapists. They've all been very supportive and recognise the need for further training in this area. Most physiotherapists, when they do initial assessments, will ask what a patient does for work, and they find that sometimes they need a little extra information about how to support that in practice. So we've had a real positive sense from the first contact practitioner community, and we will be able to give you the results early next year. So I'm afraid it's a little bit of a fudged answer there, in that it's positive, but we don't yet have the hard results of the evaluation as yet.
I would call that a tease answer. You're not actually telling us yet, but
I don't have any results is the problem, Joy, not at the moment. So,
so stay tuned.
Stay tuned, I will get that out there.
Yeah, that's great. The next question is, would it be possible to elaborate on the training you provided to the physiotherapists in order for them to be vocational advisors? I think you said it was a 5-day program.
It was essentially, so we had a 4-day program with 1-day refresher at the end, just before they started to see patients. So we have reported on the development of the intervention. That paper has been published if people want to look in a bit more detail. But to summarise, we essentially used a method of classroom-based training. So we had our vocational advisors come into us and we delivered the training on a face-to-face basis. That involved some lecture-style training. We used case studies, and we asked our vocational advisors to use the skills that or the knowledge that they'd got from the lectures to try and tackle a case, as it were. And we followed that through the whole program. So that training included an element of understanding musculoskeletal conditions, understanding the value of work to health, but also understanding the potential impact of health on work. We looked a little bit around goal setting, what case management is and how you run that effectively, what stepped care looks like and how you manage that effectively. There were skills around conducting consultations over the telephone, because that's quite a different skill to conducting a consultation face-to-face, as well as a lot of information around what support can you provide. So when you ask someone, is there modified duties available at work? What do you mean by modified duties? And how can you guide patients to think through that themselves to identify the solutions to their difficulties? It was quite a comprehensive training programme, and it was based on current evidence provided through journal articles, but also through reports and through other vocational training services that we were aware of at the time. It's going back a few years since this training was undertaken, so we're revising that for the current trial that we're undertaking.
That sounds great. Did you say that this has been published? And if so, would you be able to share through Yusra after this process, after this session, a link to that reference?
Absolutely. So the content is published in the Journal of Occupational Rehabilitation, and I will share that afterwards so people can have a look in depth at the content of our intervention and how we trained our vocational advisors.
Fantastic. I had a question that was related to this. This is my own personal question, so I'm going to grab the mic on this one and just say, what led you to choose physiotherapists as your vocational advisors?
We didn't choose them as such. We had job opportunities open for any clinical background. So we were looking to recruit nurses, potentially occupational therapists. It just happened that it was physiotherapists that applied for the role. I would say that's because it was focused on managing patients with musculoskeletal pain, rather than it being something necessarily that different about physiotherapists or the other health professions. But it was open to any health profession at the time.
Right. And do you think it would have made a difference? Would you have been happy if it had been OTs or psychologists or?
I'd have been perfectly happy with anyone. I think the point of it was to deliver vocational advice and not to deliver the clinical advice, yes. Which was a challenge for our vocational advisors. And I think that would be a challenge for anyone to take that clinical hat off and change it. But yeah. I think the theory and the advice given can be delivered by any trained individual. We don't think it has to be a physiotherapist in this regard.
Fantastic. Okay, next question. What are the components rendering primary care effective? how early should it be accessible to the patient? I think you said you were moving it back to 2 weeks. Is that right?
Yeah, I touched briefly on that within the talk. So we did find that patients, vocational advisors and GPs said actually offering it to people who are struggling with work is too early for some people. And it might be better use of resources to limit that to people who've had a period of work absence. So unreported data, but we went back to our data set and we looked at how effective the intervention was for individual patients dependent on the duration of their work absence. And we found that in individuals who'd had 2 weeks or longer, our intervention was much more effective than in those individuals who'd had no work absence or less than 2 weeks. And so that's why we have limited it within our next trial to 2 weeks or longer being away from the workplace.
Right. So moving on to the next question, if you don't mind, what are the major barriers and facilitators in regards to implementing early and brief vocational advice services to support patients? What are the major barriers and facilitators?
So some of this we will also be investigating in our iSwap project, where we're looking at barriers and facilitators to implementing it in services that are already running and delivering healthcare. In relation to setting it up outside of that arena, we found that there were difficulties in embedding the service in primary care, partly because it's an unknown entity. It's not something that we currently have in UK primary care. And the other difficulty with that is that we don't have a clear workforce to staff this type of intervention in primary care as it stands. So we are looking as part of other projects at how we could address some of these barriers to doing that, and to develop the workforce to be able to provide good quality occupational health advice within the primary care arena. That's partly led us to look at delivering vocational advice alongside other clinical disciplines, such as our first contact practitioner physiotherapists, and we'll look at the barriers and facilitators in detail there. In terms of facilitators, we've had a very positive response from the primary care community. Our general practitioners that we invited to take part in the trial were very positive about having some support to manage this. It is very challenging within UK primary care at the moment where clinicians have 10 minutes to assess the patient, to refer them to any other services they think they need, and also to provide prescriptions or write a fit note as the patient needs that as well. So fitting in vocational advice within that is a real challenge. It is challenging in other services as well. Our first contact practitioners get 20 minutes. So it's more than the general practitioners, but they still have a lot to achieve within that 20 minutes. So I think adding it alongside usual practice is one of the challenges. But one of the main facilitators is that it's been really positively received and people are willing to try and implement it in their practice.
Great. So I have another question for you. Is there any follow-up with this, with those interventions to see if they are still effective? And any idea about the frequency of the training in order for it to be effective?
So I'll take the first question first and then do the second one for you. In terms of follow-up, we followed up our participants over 12 months and we found that it was still effective at 12 months essentially. Whilst it wasn't statistically significant, we still found a 4-day difference in work absence between our intervention and our control groups. So again, I would argue that's probably more of a social significance, but that again allows it to be quite positive at 12 months. We also found that the difference in absence was primarily made up between self-certified absence and general practitioner certified absence. So our intervention group was self-certifying more days absence compared to our control group, but our control group were having more general practitioner days absence than self-certified. So essentially that tells us that our patients in our intervention arm were beginning to self-manage their health and work, which was one of our secondary outcome measures around confidence to manage their return to work themselves. So we did find that at 12 months. We haven't looked any further than that 12 months for a number of reasons, but I think still showing an effect at that duration is quite positive from this particular trial.
Yes, I would agree, because so much can happen after a 12-month period that could have an influence that you're not in control of.
Yeah.
Yeah, so I think 12 months is fantastic, actually. Sorry, go ahead.
I was just going to say it's quite following people up over 12 months and looking at work absence is a pretty long time, I think, in the work absence literature. So I think we did quite well to track these people down.
Yeah, I would agree. I think your follow-up numbers were really impressive. I had a question about the content of the intervention, and whether, I think you made a comment in passing about how it was good to have your pain in a sense acknowledged and legitimized through this process, which the GP often won't have time to do. And I was wondering whether just having somebody to talk to was as powerful as having somebody who actually did a lot of the vocational part of the advice giving, and you didn't have a control group which just did, somebody to give counselling or some general time to talk about their condition, to compare it with how important the vocational piece itself was to the intervention. Did you have a sense that that there was a way of teasing apart these two pieces of the intervention, or do you see them as sort of so interlocking that you have to do both in a way?
It's really very difficult, I think, to extract the therapist effect from the intervention effect in any intervention or consultation. I do think that's quite challenging. One thing that I would note was that this was offered as a service, so patients could be referred to it and they could choose not to come. Of those patients who were referred, we found that over 75% of them had engaged with the service. So that tells me that patients felt there was a real need to have these conversations. Whether that they were looking for the vocational advice or they just wanted to talk a bit more about their problems, I think is difficult to pull apart in this particular trial. But certainly the therapist effect and having someone to talk to could be a strong reason for the findings, or part of the reason for the findings.
Oh, I'm just seeing we're coming up to 3 minutes before we need to part company, and I wondered if there was, if you had one message to our attendees to take away from this webinar today, what would that be?
I think the message to me would be to talk about work, talk about your health in the context of your work, and to remember that work is good for most people. Remaining active is good for most people. But I think we need to have these conversations as clinicians, not shy away from them, and as patients and employees, again, don't shy away from these conversations. The more we talk about it, the more we can have discussions around helping people to manage their health in the context of their work.
That's fantastic. Thank you very much. I learned a lot, and I'm sure so did all of the other attendees. I'd just like to thank you genuinely for a fantastic presentation. Thanks again. And can I hand over now, I think, to Yusra to round up, if that's appropriate?
Yes. Thank you so much. It's a pleasure to have you both live with us today. Thank you, Gwen and Joy. A fantastic presentation. Thank you, Gwen, for shedding some light on the impact of musculoskeletal pain on the working age population, and for sharing your research that shows that an early, brief, and low-intensity vocational advice for adults with musculoskeletal pain in primary care goes a long way in reducing absenteeism and contributes toward a better retention of the workforce. And thank you, Joy, for moderating the webinar and for making the time to be with us. Thank you so much to our audience as well for your participation and for being with us.